Amazing.
Do you think that's everyone for today?
I think that is everyone for now. We are now live and we are now recording. So welcome to today's lecture, everyone. I just wanted to welcome back Dr. Mane, who graduated from Palacky University in 2019 and is now working as a surgical SHO in the UK. And she's going to talk to us today about ENT cases and airway management. So it should be a really useful talk, especially for ALS.
Indeed. Okay, let's get started. Thank you, Preet. So, like I said, my name's Rashi. I think a few of you met me last week. So we're going to focus today on ENT and airway because right now I'm working in ENT and you realize how important airway is, especially if you're doing ALS. A, B, C, D, E. A comes first. A is airway. So if we look at the anatomy, just to know about the passages, what you can see here, I don't know if you can see my cursor. This is the nasal cavity. You can just see the inferior turbinate. This is the nasopharynx, oropharynx, where the tongue is up until the epiglottis. This is the epiglottis here. Then you have the hypopharynx up until the larynx, and then the trachea to follow. Yeah. Over here, you can see the vocal cord. So you have the epiglottis once again. You have the tongue over here. And then behind, you have the esophagus. Where the esophagus meets the oral cavity or the hypopharynx, it's the piriform fossa. So sometimes you can see some drooling here. And that's a sign of an airway or an obstruction, either lower down in the esophagus or upper. That's why there's some swelling or something. And that's why you can't swallow that drool. What else can I say in this slide? I did want to also mention that there's something called obstructive sleep apnea. So that can be caused by multiple reasons, either from the nasal passage, if the adenoids, which are usually situated at the back of the nose, are either too large, or if the turbinates, which are basically the soft mucosa on the lateral side of your nose, if that's inflamed, then that can cause some obstruction. Your tongue can also cause obstruction when the tongue base is too large, as well as the pharynx wall. If that's edematous, then that can cause an obstruction. And lastly, the last thing that can cause obstructive sleep apnea is your tonsils. You can't see it in this image, but your lingual tonsils usually sit just behind the tongue. So if that's too large, then that can cause an obstruction, aka you can't sleep at night without waking up. And usually we have to do something about that. This is just another view of the cartilaginous structures. So you need to know the hyoid bone. I remember this like hyoid, the high structure at the top. Then you have your thyroid cartilage, which is basically your Adam's apple. And then you have your cricothyroid cartilage, which is right underneath. Why this is important is because you need to know that in the cricothyroid ligament, which is this area here, you're going to make your little stab. Say if nothing else works when you try to intubate, you have to either do a percutaneous cricothyroidectomy or a surgical one. But I don't think you need to learn how to do that just yet, so we won't bore yourself with that. So airway obstruction is always a medical emergency. Like I said, when you do A, B, C, D, E, A always comes first. So you have to make sure that your airway is patent. I'll always say airway patent when you think that the airway is still flowing, because that's just a key term that they like to use. When it's obstructed, it can cause a loss of consciousness. It can either be partial or complete, depending on any level of the respiratory tract. And if it's left for a long time, it causes lowered blood oxygen, causes hypoxia to the main organs such as your brain, kidneys, and heart. And if this prolongs for a very long time, it can lead to death. I think if you remember your death cycle, it takes like 3 to 5 minutes for a hypoxic brain to cause brain damage and then death. The most common cause of an airway obstruction is in the pharynx is either the soft palate, which is the soft part you feel right at the back. So you have the hard palate that you can feel with your tongue, and then right before with the dangly thing, the uvula, that's your soft palate. So that can be a cause of an obstruction, as well as your epiglottis down below, usually found in kids. So the causes, this can be split into 3 main causes, either intramural, which is in the wall. This is caused by like a tumor of the larynx, paralysis of the vocal cords, usually secondary to surgery. So Vocal cord damage usually happens in thyroidectomies, epiglottitis, and subglottic stenosis. So anything below the epiglottis, that when that's stenosed, that can cause an obstruction. Then you have intraluminal, which basically means inside the lumen, and this is usually caused by a foreign body or any secretions such as blood, excessive saliva, those type of things. And lastly, extramural is usually outside of the wall. So any tumors that are pressing against the airway, any abscess or hematoma, which you usually find in the just behind, even superficially on the neck. If it's that large, it can press on your airways. Lastly, pulmonary edema, when you have an overloaded lung, that can cause airway obstruction because you're just not getting that ventilation. And lastly, aspirations of gastric secretions. Now, this is really important, especially in a surgical patient when they've been intubated for a very long time. When you extubate the patient, you increase the risk of aspirating gastric secretions. Any liquid greater than 20 ml can cause like detrimental effects on a patient if they get fluids in their lung. It causes like hospital-acquired pneumonia, and it can lead to death. And lastly, of course, trauma. Trauma is in everything. So how do you recognize obstruction? So there are 4 different ways. If you have an inspiratory stridor, so this is usually an upper airway problem. So that's where ENT comes into play. So this is like larynx or above. When I say inspiratory stridor, this only happens on inspiration. So it's like you're making a sound when you're inspiring, not when you're expiring. When you're breathing out, it's completely normal. The second one is expiratory wheeze. Now, this is a lower airway problem. So this is when you've got problems like with asthma. This can cause you to feel like out of breath when you're expirating. Then you have your paradoxical movement, which is basically known as the seesaw respiration. So if you see the image below, your chest and your abdomen work against each other in the sense that if there's a full obstruction, your abdomen, which is your accessory muscles for breathing, tends to work faster than your chest, and that's why you get the seesaw motion. And lastly, which is a very late sign and you'd hope to never see, is central cyanosis. So like your chest, your face, that's all blue, not your peripheries. But if that's the case, that means that you've been hypoxic for a very long time. So how else do you recognize it? It's the usual look, listen, feel. Always know this because that's basically how you assess the airway. Look, you want to look for your chest and abdomen movement. Like I said, they need to be in conjunction with each other, so they should be moving in the same direction. Listen, so you want to hear the air sounds. There's like different sounds that you can see and that would depict like what kind of obstruction is. So if you can hear it completely normally, there's no wheezing, no stridor, that means that there's no obstruction. If it's slow or absent, that could mean that there is either a complete or partial obstruction. Gurgling is usually a sign of a liquid presence, and snoring usually means that the pharynx is obstructed either by a solid material. Usually in this case is the tongue, can be the tonsils. Like I mentioned earlier, this is usually where obstructive sleep apnea comes. And lastly, you want to feel. So you want to feel the airway against your cheek. So you want to sit there for 10 seconds. I know this sounds really strange, but you want to put your like cheek to the mouth or nose, and you want to feel the airway or the breathing. Another way to avoid putting your face there, especially in COVID times, you can put like a metal spoon or something, and you want to see that misting. Okay, so assessing the airway, there are a couple of ways that you can do this. The most important one is the Melon-Patty score. So as you can see, there's 4 different classes. In class 1, this is the best one. You can see everything. So you can see the soft palate, which is right at the back where the uvula is there, and the pillars, which is the structures that are next to the soft palate at the top. So where your tonsils sit just behind. In class 2, you can just about see all these structures, but it's limited to just the top part. In class 3, you can see the soft palate and the uvula, not so much the arches, and only the base of the uvula. And class 4 is when the soft palate is just not seen, you just see the hard palate. Now in class 3 and 4, this is when you're going to have that difficult intubation. That's when you want the anesthetist to be on hand, and you have to be wary of whether or not you might have to lead to like surgical intervention. Another way to assess this is, so do you remember those bones that I mentioned earlier? You have your mental, which is your chin, then you got your hyoid bone, which is the higher one, then you got your thyroid, and then you got your sterno, which is basically the sternal notch where your manubrium is. So if your thyromental distance is less than 7, that usually indicates difficult intubation. Once again, if your sternomental is less than 12.5, that's also another cause of difficulty intubating. And lastly, you want a gap between your two incisors of at least 2 centimeters, because when you're inserting your laryngoscope, you need that distance to actually get to the back, to the epiglottis, so you can insert the tube in, essentially. So choking, this is usually the most common cause of an airway obstruction, and this can be caused by foreign bodies, or even like foreign materials, like I said, the gastric secretions, vomiting, blood, those type of things. It can either be mild or severe, and you can remove it either with suction, a laryngoscope where you open up the mouth, and if it's just able to reach, you can get some forceps or some tillies, also known as McGill's, to pick it out essentially. So with suctioning, there's a few things that you need to be aware of. You need to make sure that the patient's airway is kept clean from foreign materials, of course, because like I said, if you aspirate anything more than 20 ml, that can be detrimental for the patient. Like I said, complications are severe pneumonia to complete airway obstruction. The way to remove this essentially is suctioning, and what you do, you have to do it only for 15 seconds at a time, because if you do it for longer, it damages especially the soft palate because it's very sensitive. And not only that, you need to make sure that you only suction where you see, because you don't want it to end up damaging any structures there, because actually in the oral cavity you have really important vessels and tissues that you don't want to mess around with. As well as if you go too far down, then you might end up pushing the foreign body further in or pushing down the secretions, which you don't want to do. So this is just a picture for you to know. The Yanker sucker is what we usually use, and I'm sure you've come across that if you've done some clinical work. The flexible catheter essentially works as a suction. What you do, when you would usually see this is in tracheostomy patients. So tracheostomy is basically a stoma at the trachea, so you go directly to the airway, and this will be able to clear up any mucus plugs, because that's usually their cause of airway obstruction. McGill's forceps are these special forceps that have that curvature that can go down to the back of your throat if necessary to pick it out. And this is just the suction wall mount that you would usually see. You'd put your tubing for your suction on this area. Yeah. So this is an algorithm usually used by our ALS manual. And this is how you would deal with a foreign body obstruction. So you want to assess the severity. If it's mild, aka they're coughing and it seems like they're clearing it out, you just encourage them to cough, rub their back and get them to cough a bit more. If it's severe in the sense that they're now turning like blue in color, you need to realize, are they unconscious or conscious? If they're unconscious, straight onto CPR, because remember, chest compressions save lives. If they're conscious, then you've got the 5 back blows. So that's basically you hit really hard between the scapula at the back. And then after that, if that's still not working, then you do the abdominal thrust, which is the Heinrich's maneuver. I forgot to ask, if at any point you have any questions, feel free to ask. Now moving on to the basic techniques to open the airway. So this is our usual head tilt, chin lift, and jaw thrust. So why we do all of these is basically, if you can see at the bottom image, when you're usually sitting like quite, if you're lying down normally, you can see that the airways is slightly closed. This is the esophagus, this is the airway at the front. So you can see that the epiglottis tends to sit on the back wall. So why you do the head tilt is because it makes everything more anterior to the neck and opens it all up. The chin lift you usually use with your 2 fingers, and you just lift up the chin below the mental. And then the jaw thrust. Why this is also good is to understand how conscious the patient is, because this is usually a very painful maneuver. So if they're tolerating it really well, then that's a sign that the GCS is probably less than 8, and we need to think about intubating them in the near future. So how you do the jaw thrust, you basically put your 2 fingers at the angle of the mandible, and your thumb, sorry, I can't do it on this side, just above, and then you use that to, how am I doing this? So you put your two fingers at the angle of the mandible and your thumb at the mental, and you basically lift it up. And you want to actually see, so if you're finding out the oxygen saturations, it actually goes rapidly up if you've done it successfully. So adjuncts. So what adjuncts basically are how do you open up the airway in a simple fashion? So the two common ones that you'll see is a Goodell, which is an oropharyngeal adjunct, which is this at the top, or a nasopharyngeal adjunct, which is basically a tube that you'll put into the nose that goes to the back of the pharynx. Why you do this is that it either helps aid increased oxygen flow inside, or if you're doing prolonged resuscitation, it usually allows you to continue for a longer time without having to jump into a proper intubation. If you do this with addition to anything else, like I said, it just increases the oxygen. So that's why we would use it. Just to describe where they all go. So usually how you assess where they go or the size of it is you just look at the diameter of the nostril and you play it by eye, but usually it's around 6 to 7 millimeters for adults. For the oropharyngeal adjunct, you would see like an orange one you usually use for a male or green for a female. I'll go on to describing how you measure it. So like I said, a nasopharyngeal airway is the ones that would be tolerated in a conscious patient. And why it's good, you usually use them in ones that have a clenched jaw, either because they've got a spasm in the muscle, trismus, for multiple reasons, especially in ENT, even like tonsillitis can cause trismus. Those that aren't familiar with the word, trismus is basically when your mouth just doesn't open because it's like a locked jaw, or any other jaw injury. So if you just put it into your nose, when you put a mask on top, it gets more air oxygen flow to the back. Be warned to never use this when you have a skull base injury, because your nose has a delicate bone there called the cribriform plate, and if that's like probably damaged, you can cause further damage to your brain, and that's what you don't want. Like I said, to size it, you look at the nostril. The length is usually dependent on the size of the nostril itself, so it's a 2-in-1 there. And to prevent inhalation, which actually can sometimes happen, once you put the nasopharyngeal tube in, you put a safety pin on top to sit on top of the nose, not through your nose, of course. We've had some people do that by accident. That's not good. Then you've got your oropharyngeal airway. So these are those curved tubes, and the way to remember how to size them is heart to heart. So you go from the angle to the jaw to your top incisors, and you measure it that way. So you want so if you go back, so you want this part to be in front of your teeth, so you're biting down on that. You have to realize that this is actually not very well tolerated, because essentially you're choking the patient. So if they're tolerating it, then that's not a good sign. Like I said, it shows that they're probably unconscious. But of course, if they're not tolerating it, take it out. Don't force it in. And that's that. The next thing you would use is a pocket face mask. So what this basically is a small little face mask that you put on top. You would use the diamond structure. So you hold it like this on top of the face mask to keep a tight seal. You want to do the whole head tilt, chin lift, jaw thrust in this action as well, because you're opening up those airways completely. And the way that you will now give air is through the inspiratory valve, like the doctor here is doing. You just blow inside. You usually have a limit to how much you can give. You can add in extra oxygen through a reservoir valve, but usually in a pocket mask, you don't see that as often. Then the better thing to use is, as opposed to your breathing, because obviously you're breathing out CO2, so there's only so much oxygen you're going to give to the patient, is using a bag in addition to the mask. So this is how you'd connect it. And obviously some people forget to connect the oxygen to the bag. So if you want to actually increase the percentage oxygen you're giving, don't forget to give that oxygen. But obviously in some cases you don't have that oxygen readily available. You just have to pump that bag not as frequently, sorry. You have to mimic your usual rest rate, so between 18 to 20 per minute. Because each bag, you don't want to push it in as well, because that causes damage to your lungs. You want to do it in a gentle motion like that, because it delivers 500 ml per air or breath, which is similar to your tidal volume actually. And like I said, once again, you do the head tilt, chin lift, jaw thrust with this movement again. ALS usually prefer you doing it with the 2-man technique, like the ones that you see below, so that you keep that strong seal, and then you have someone pumping the bag to maintain that timing. But obviously, when you don't have the people available, it's fine to do it once, but you have to realize that the seal is just not going to be so strong if you haven't practiced. It seems like a overwhelming one, but this is the one that you would see most commonly. It's called an oxygen non-rebreathing mask. Why it's called non-rebreathing is because you don't end up taking any exhaled air back into the mask. Essentially, it comes out of the expiratory valves that you see here. You would use this in trauma emergencies, in asthmatic patients, anyone with an MI, or pre or post operative, because they've been under low oxygen levels throughout the whole operation. So you want to get that high volume of oxygen back, or if they're in respiratory distress, because the point is that they can still inspire and expire by themselves, but they need some help get that oxygen because they might be hyperventilating. It's designed to take oxygen more higher than 10 liters per minute. So obviously in your usual emergency situations, they say 10, but you should give around 12, and it delivers around 80 to 90%. So out of all the masks, this one had the best percentage. So how to improve the mask seal tips. So there are some situations that might cause you not to have a good seal. It could be because of lack of experience, so you just need to make sure that you practice. Another one is that you need to know that if you have a larger mask, contrary to belief, it actually gives you a better seal, because maybe it just has better surface area. Usually people think with a softer mask, smaller mask, it can cause better seals, but that's not the case. If you have a big beard, you should lubricate it, because it basically mats it down and it causes like a sticky situation. So that way you don't get any air leaks from the side. If you have no teeth, essentially your cheeks end up getting sucked in, like you become gunty like that. So what you can do, you can stuff gauze sponges inside the cheeks to keep those keep the airway open, essentially. So when you're inflating the mask, air is actually going in and it's not just getting lost in the oral cavity. If you're obese, there's the reverse Trendelenburg. So that's when your head is lowered and your tummy is up. So this basically takes off pressure from the abdomen and air goes into your lungs. And also you need to avoid pushing down on the soft tissue, because that can cause airway obstruction actually. And lastly, always use those adjuncts that we've initially discussed to improve that saturation. So this is just an overview or a table to show how much oxygen goes in with whatever you're using. As you can see, like I mentioned, the non-rebreather mask is the best way to get the maximum oxygen. So if you have a patient that's unconscious, you want to get one of those on as quick as possible. I forgot to mention with the non-rebreather, don't forget to actually inflate the reservoir bag here. The way you do that, you cover the valve, because if you don't inflate it, then you're not actually getting the patient any oxygen, which defeats the purpose. So we've tried ventilating and that's not working. So then you intubate essentially. These are done by supraglottic airway devices. The ones that you'll come across is a laryngeal mask airway, which is what you see here. The importance here is to make sure that the cuff is actually working. So you would inflate the cuff here and you have to make sure that there's no airway seal leak. So when you inflate, deflate, make sure it's puffed and it stays turgid. Then you have the eye gel. So that removes this whole possibility of not having a functioning cuff. It's just a plastic, but it works the same way. These are really easy to insert. You basically just have to follow the tongue up until the epiglottis, sit it straight and inflate it, unless you have an eye gel. And I think there's someone asking a question. No, just me. Okay, and then you have, let me just check.
Sorry, yeah, they are. Is an intubation a type of ventilation?
Right. So ventilation is passive, whereas you intubate, and when you intubate, it's basically you're doing a more invasive technique to make sure that air goes directly to your larynx slash trachea downwards. So when you ventilate, you're mimicking the passive movement that we do when we respirate. But when you intubate, you're basically you're going to control where the air goes, because you're trying to, I don't know if that makes sense. So you're trying to control to make sure that it goes straight to the lungs, because you know that they're not ventilating well through passive techniques. I hope that answers that. So like I said, where was I? So with intubation, okay. Oh, okay. So there are ways that you can improve intubation, or when they're difficult, like I mentioned in the first slide, if they have a myelopathy of 3 or 4, you need to use these aids, which is called a bougie, is one of them. So it's a very thin guide wire, essentially, which goes all the way down to your vocal cords, which is where your SADs are going to sit on top, and then you follow through with the endotracheal intubation. You can use a video laryngoscope. So as opposed to a rigid laryngoscope, you have a video attached, so you can see exactly where you're going when you insert it. And lastly, there's something called the Sellex maneuver. So it's basically right and back on your thyroid, essentially, and what that does, it pushes the line of the airway in one line. That way you can intubate it easily, because it's all like in one line. So this is known as the difficult intubation guidelines. So this is a quick overview. So what you're going to do first, you're going to use a laryngoscope, and if that's fine, you're going to use the tracheal intubation. Say if endotracheal intubation doesn't work, because that's a superior intubation, then you're going to try using the easier ones, such as the eye gels or the LMAs. If that works, then you have to think, okay, is this good for long term? Because usually you would only use that for 90 minutes. But if you feel like the patient isn't going to wake up in that time, then you have to think about, how do we switch that over to endotracheal? Say if that fails, then you go back to your face mask ventilation. And if that doesn't fail still, that means there's a complete obstruction above the glottis. So you have to think about a cricothyroidectomy. If you go to this page, so this is where you would do your cricothyroidectomy. Here, the first thing you would do is a needle cricothyroidectomy, just to open that up to get some air into them. But that's only actually good for 3 minutes max, so like for 90 seconds to 3 minutes actually, and after that you need to think about a surgical cricothyroidectomy. Like I said, I won't describe how you do that now, because I think that's not necessary. And once again, cricothyroidectomy also isn't a long-term management, so especially in ITU patients, you have to think about a tracheostomy, so it goes straight down to the lungs through the tracheostomy site, which is between the second and third tracheal rings. So now we're going to go through some cases just to describe a normal neck x-ray, because a neck x-ray can actually show you a lot of details. You've got your nasopharynx at the top, which comes down here, the uvula, which you don't usually see, but you'll see it as a more opaque structure just below the nasopharynx and above the oropharynx. This all goes down to the oropharynx. So air is always black on the x-ray, so remember that. So if you see any hazing above, that's usually your adenoid tonsils. If you see any below, that's usually your lingual tonsils. Right here is your epiglottis. It's another opaque region that you'll see below. Just above that is your vallecula. Why this is important? Because especially in ENT, loads of people eat fish and they don't seem to want to take out the bones. So bones tend to actually get stuck in the vallecula. Then you have your piriform sinuses, like I mentioned. So this is the opening. So actually this opaque region here is your esophagus. It's not actually a tube that you can see. So your piriform sinuses just sit on top of that. And then over here you have your trachea. Okay, so I've got some things labeled just to give it away. Let's see if anyone knows what I'm pointing at here. Does anyone know? What do you think this is and this is? And if it's causing some airway obstruction, what do you think the cause is? I'll give you 5 seconds. I know these are a bit tough. If not, then I'll just explain it. Anyone?
Not had anything in the chat just yet.
Shall we just go to the answers?
I think maybe.
Yeah. No worries. So this is tonsillitis or infectious mononucleosis. So this was actually a 16-year-old girl that came in, and she showed the worrying signs essentially of an airway obstruction. So you're going to have that hot potato voice. You also might you'll see some drooling and difficulty swallowing. Now this is when they need to be admitted, because obviously if someone can't swallow and they can't eat, then how are they going to get that nutrition to get better? So what you're seeing in the black arrow is your adenoid tonsils, and what you see with the white arrow is your lingual tonsils. And what you see here is the narrowing of the nasopharynx. So if it's infectious mononucleosis, you need to remember never to give amoxicillin, because that can cause a rash. So whenever you start treatment for basically an enlarged tonsil infection, what you need to do is you need to treat them for both, either tonsillitis or infectious mononucleosis, while sending out that monospot test. And you need to start them on phenyl benzyl penicillin. So this is basically something that won't give you those adverse reactions if you do have infectious mononucleosis. And another thing you need to realize with infectious mononucleosis, it's viral. So actually, as soon as you realize that's what the case is, you don't need to give them any antibiotics, because it's not going to help. You need to tell them to rest and drink a lot of fluids, because infectious mononucleosis makes you very prone to splenic injury. So you tell them to not do any contact sports for 6 to 8 weeks. But obviously, if they have a narrowed airway, the best thing to do for them is to give them some IV steroids. Usually we give dexamethasone 6.6 mg. So this one, I feel like I should just go through all of this. So I need you to basically take note of where these arrows are pointing. Like I mentioned before, this is your epiglottis just below there. So you can see all of this extra tissue around that. This is known as epiglottitis, and this is an airway emergency. This sign that you're seeing around the epiglottis when there's so much swelling is known as the thumb sign. So like I said, any airway obstruction, you're thinking of the triad, which is a change in voice, any drooling, and systemic illnesses, which is like fever, tachycardia, those kind of signs. You need to start thinking, okay, this is an emergency. How do we make sure that the airway remains patent? So like I said, epiglottitis is usually in younger children, and that's when it's a fatal, because their airways are already as narrow than they usually are. So you need to make sure that you do a F&E. Let me see what. Have I ever seen? I actually have. Literally yesterday, someone came in. But luckily it wasn't. It was in an adult. So like I said, it's not as fatal, because the airways can be, they can tolerate a bit more swelling, I guess, than younger children. So essentially you need to give them the steroids, because that decreases inflammation. And then you need to start them on broad spectrum antibiotics.
We've just got a question in the chat, sorry. Why do you give phenoxymethylpenicillin if they've got EBV, a viral condition?
That incorrectly. So like I previously mentioned, it takes a while to get you that monospot test to differentiate between tonsillitis and infectious mononucleosis. I probably should have put a drawing out or a diagram of how it looks, but you can see the tonsils at the back of the throat. Very enlarged, very red, and then you'll see a lot of pus on both of them. On tonsillitis, actually, you'll see less pus, and sometimes it's more on one side than both. Infectious mononucleosis, you're going to see very pussy on both sides, usually actually coated in white. Another way to differentiate mono, or to think it might be the case, is that your liver function tests, they're completely off, like they're deranged. So if you start seeing liver function tests being off, inflammatory markers being raised, and that exudate coating on your tonsils, you're going to start to think infectious mononucleosis. But there's no saying that tonsillitis can't cause those things. So you shouldn't actually stop the treatment for tonsillitis because you're waiting on those results, because that usually takes, say, 24 hours. So you're potentially telling the patient, oh, I'm not going to treat you for 24 hours because I haven't got that diagnosis. So that's why you would start them on that and not amoxicillin.
Sorry, and Hashim's just asking, is X-ray film used to diagnose these conditions?
So no, so I thought x-rays might be fun to see. So usually tonsillitis or infectious mononucleosis in particular, you can see with blood and just a clinical examination. With epiglottitis, an x-ray is beneficial because you're going to actually see the thumb sign as well as how bad is the airway. But superior to all of this, or in any airway obstruction, you want to do an F&E, which is a flexible nasoendoscope. Basically a small little camera that goes through the neck all the way down to your vocal cords. So you can see how patent that airway is, because you're seeing all the areas that can be obstructed, like I mentioned earlier. So your nasal cavity, you're going to see if your adenoids are too enlarged. You're going to see the back of your throat if that's edematic, especially in anaphylaxis, and you're going to see if your vocal cords are still working. Because like I said, in thyroidectomies, your vocal cords can get damaged. And when they're damaged, aka the vagus nerve is damaged, it can cause them to be paralyzed. So the slip between the two is basically very little, basically causing you that inspiratory stridor. But yes, I would say an x-ray is always beneficial. Airway obstruction, why not get it done? Because it's good. F&E, superior. Bloods should always be taken just to see if there's any infection.
Sorry, there's just one more. When using a scope,
No.
is the patient under general anesthetic?
No, actually, they're usually either, depending on the patient. So actually, I prefer not to give any local anesthetic even. It depends on the skills of the doctor doing as well, because obviously your septum is very sensitive. So if the camera ends up grazing against it, you're going to be in so much pain. Also, if the patient has really bad gag reflex, then when it goes at the back to your uvula, you're going to feel it a lot and they're going to start coughing, especially in COVID. You don't want that. So you just spray some local anesthetic. GA, I would only suggest doing if the patient is either they have like developmental issues where they just can't tolerate it, they're not steady, they're not still, or they're very anxious that they really can't tolerate it under local. But it's actually painless and it takes like 2 minutes and it's a quick diagnostic tool. So no, you don't need to do on the GA. So this one, this x-ray, why I showed you this one is, okay, so the black arrow actually is a foreign body. So this patient ended up eating a bone, usually it's chicken bone when it's so opaque. And what this caused was surgical emphysema. So this is what the white arrows are pointing at. So this is loads of air under the subcutaneous tissue. And that's why it presents like this. So you can't actually see a nice black line where your airway would be. It's just this big hazy mesh. Why this is worrying is because this can indicate an esophageal perforation. This is when you need your GI team to get in play, because you need to essentially intervene and make sure you patch that up before it becomes a bigger issue. Other causes for surgical emphysema in the neck is trauma, as well as Boerhaave syndrome. I don't know if you know that, but it's basically when there's a cut in the esophagus, which can cause gas leak. Like I said, always remember the triad when you have an airway obstruction. Make sure, because that will test the severity. Are they dysphagic, aka they can't swallow? Is their voice, have they showed any changes, loss, or is it hoarse? And lastly, if they're systemically unwell. This is the last one. So I don't know if you can notice. So in our left picture, actually here, just below, you can see a foreign body. Usually, actually, they're really difficult to notice, especially when they're a fishbone. And they can usually be you can usually say, I can't see anything, you can go home. But the problem with leaving a fishbone in your pharynx is, your esophagus, it can cause a retropharyngeal abscess. So this is basically infectious tissue that's accumulated and made like a pimple, you could say, inside your esophagus. And what this does, it pushes on your airways, causing that airway distress. And this can be potentially very fatal, very harmful if you don't surgically remove that abscess. So what we would do with a fishbone scenario, because we get loads, you obviously ask them about their symptoms. When did it happen? If it happened quite soon, then you would actually be like, okay, they had to come in straight away because they're not tolerating it. Then you have to ask, is there any changes in voice? If there's any drooling, because drooling basically means that there's an obstruction there and they can't swallow. Then you have to ask whether or not they can feel any like air under their skin. And then you have to ask, what do they exactly eat? It's because if it's a fish, then you have to be slightly skeptic if you can't see anything on an x-ray. And usually you would do an F&E to confirm. And like I said, you would see a fishbone actually sitting in the vallecula, which is this area just above the epiglottis. Say if you don't see anything, you've done an F&E, there's nothing, you'd say, okay, go home. I'll call you in 3 days to make sure that nothing's persisted. If you don't see anything, but it's strongly indicated that they actually have something, because usually instead of having a midline pain, they're going to feel it only on one side, then you'd say, okay, let's just take you to theatre and examine you under GA, because the last thing you want is this retropharyngeal abscess, because that's basically due to your negligence, and you don't want that on your karma. So yeah, that was everything. Thank you. This was for upcoming lectures. Does anyone have any further questions or anything about ENT that I can help with or anything? If not, that concludes today, and thank you.
Hi, thanks so much for the talk. I actually have a question. What is an F&E?
Okay, so an F&E is a flexible nasoendoscopy. So
okay.
Endoscopy. So it goes through the nose endoscopically to go and look at the larynx and above.
Okay, perfect. We've got one more in the chat. Question about adjuncts. You mentioned if the patient isn't tolerating it, take it out. Are there any complications that can arise from the patient fidgeting, moving due to discomfort, etc.? Or in other words, how much complaining should we as a doctor tolerate before just removing the adjunct?
So like I said, so with the nasopharynx, you can actually it's tolerable in any patient. So if it'll obviously be uncomfortable because you're sticking a tube up someone's nose, which shouldn't actually be there. So obviously with that one, I think you can take it with some skepticism, unless there is suspicion of a skull-based trauma. Then I guess you would stop there and then. With an oropharynx, pharyngeal adjunct, you would just stop. If they're not tolerating it, it's because essentially they're awake. So don't do it.
Okay, thank you. Hashim saying, what is the bread and butter in an ENT rotation?
Fair enough. So, oh gosh, so many things. So in a typical A&E, you're going to have loads of foreign bodies, because little kids love to stick objects up anything. I've got like sweet corns, beads in noses, ears. So that's definitely one. Tonsillitis being another one, and ear infections. The ones that the GP can't handle, they end up coming to us. And then there's a couple of things that we can do. So ear infections, tonsillitis, and foreign bodies, I would say, would be our bread and butter.
Okay, that's really helpful. Thank you. Hami's saying he has his ENT final tomorrow, so thanks. If you just want to go, to the next slide, I can put the feedback form up. Yeah. So thanks, guys. If you could all just fill the feedback form, I'm going to post the link in the chat as well.
And if Cami had any questions for his ENT tomorrow, feel free to ask.
If anybody has more questions, that's also fine. Sorry. While people are typing, I'll just go through the upcoming events. So on the 19th, we have an event with USMLE guidance from one of the LF2 alumni. And then on the 20th, we have an occupational and motivational psychologist doing a session on engaging with your goals and values and how that can build you as a medical student, because obviously we are more than just medical students, and sometimes it's nice to see where we're going. So yeah, feel free to register for both of those. Just a general question, what's your most difficult airway case?
So I've actually been fortunate or unfortunate to see a wide variety. So we had a couple in ITU actually secondary to COVID, because they've been intubated for so long, which can cause stenosis of your trachea, which basically means that you need a tracheostomy. So I've actually been part of like a lot of tracheostomies recently, and on a more simpler basis, I guess we've had a couple of retropharyngeal abscesses. So yeah, I guess we've had quite a few difficult airways. Okay, and yes, please do if anything does come up. I'm happy to answer. Thanks, everyone.
Somebody's asked, after graduating, did you do an F1 or go straight into F2 standalone, and how's it been settling into the UK?
Okay, so I get this question quite a lot, actually. I went straight into F2. I didn't do standalone, unfortunately. And I actually think that was mainly because my interview skills, because I got up until the interview and then I couldn't do my clinical scenarios. So if I had any feedback, I would say practice clinical scenarios, definitely, because I don't think, or I don't know if things have changed, but when I was at school, they didn't really teach them very well. But at the end of the day, I didn't think that that meant that I wasn't ready to do an F2, because if you look at the job description between the F1 and F2, F1 is basically you're going to be doing clerking work, like all the administrative works, like discharge summaries, nothing that actually requires your own medical knowledge, which at F2, that's when you start stepping in. Obviously, you have that extra, you could say, extra pressure of having to look after F1s. But honestly, if you know where your limitations are and you know when to escalate, I don't think there's any harm in going straight to F2. In fact, I would highly recommend, because I'm like, we have the theory. If you have done any practical experience in the NHS, then that's really helpful. Obviously, if you've had none, then I might actually recommend doing at least 2 to 3 weeks of experience beforehand, and then if you feel comfortable, go to F2. But I think it's based on like the individual. If you're ready, there's nothing stopping you and nothing that should stop you. But if you're not ready, obviously do F1.
Thank you. I think that's really useful advice. PJ is just asking, do you have any suggestions about things we should start early or make sure we need to get done so as not to delay or hinder our success in specializing into ENT?
Okay. So actually, so if this is very towards the NHS system, and I think UK grads do this quite early. So it's all about a tick box. I know that sounds really sad and lame, but I think depending on what you want to do in the future, everything has a requirement score sheet. So I would highly recommend typing in that like speciality mark scheme for like the year prior to that, and then seeing what they exactly need. I think it's always helpful so audits are like everything that UK wants. So if you can do an audit, even if it's really simple, like how fluids were written on a chart, or was VTE like thrombo like VTE prophylaxis, that type of audits, like that's really quick, just get it done so that you can write it on your CV. How do you do or get audits? Basically, actually, I think you need to take initiative, especially in Czech. So when I was in Czech, I was literally like, I want to audit something, because actually the Czech students do audits. We don't. So I would say you go to the good consultant with an idea and you basically say, I just want to audit this, do it for 2 weeks. Like I said, you can do VTE prophylaxis. So how do they prevent clots from forming? That's a really quick and easy one. Sometimes they give like Clexane, or they do like some stockings. So you can see if they're doing it or not. And then you basically intervene by saying, either putting up a poster and then you'll re-audit it. Just do some really quick ones so you can write it down, because it's about what UK wants to see is that they don't have to teach you all these basics. So if you know how to do it beforehand, then that's less time that they have to do to teach you what you should already know. So audits be one. If you can do any posters, like in our university we had Swatch, and this was actually an accident for me, but it ended up being the best thing I did, because now I put it in everything. So do some research type deal. Do you write up? Sorry, I'm just reading up the questions. Okay, so usually you want to present an audit. So if you can get just a consultant or like a group of your students, just sit down and present like what you found, then that's like an oral presentation, which is like tick, tick, tick. If not, you basically intervene by putting up a poster and then you re-audit to see did that poster make a difference. But you need to have a consultant be like, okay, they did this audit successfully and I'm going to sign them off. Sometimes you have to write them a letter on behalf of them. So you say like, oh, they successfully designed and led this audit, and then get them to sign, because everything's about paperwork and evidence. So if you can't evidence it, it never happened. So just make sure that you can write something that they can talk about. Yeah. And like I said, research is another one, and all about experience. So get clinical experience down, and I think you're set for then. And then speciality, like I said, Google what you want, check the marking scheme.
And so, sorry, for research, is that clinical research, or would lab-based science projects count as well?
Oh, lab-based, any kind of research. So it depends what you like. So if you're working on something which is lab-based, that's completely fine, as long as you can write it up later. Like I said, if you can evidence it, that's all they want. It doesn't need to be anything grandeur, but obviously if you can get it PubMed cited, that's really good. There's actually a website called Stat Pearls that I didn't know, and unfortunately the cool things are kind of closed now, but Stat Pearls is a website that you can use to basically help get some publications going. So depending on what level you are, you can do a certain type of publication for it if you need some publications under your wing.
That's really helpful. Thank you.
No worries.
Can you see the chat?
Yeah, I've kept it.
Okay.
I promise I'm not just zoning out. So how is my life-work balance at this stage? So I would say, actually, personally, it's pretty poor, only because I'm playing catch up. So things that I wish I did during med school that most of our UK grads would have done, I hadn't done. So publications, I'm like trying to get as many as I can, especially for competitive fields like surgery. You need these sort of things. And I was trying to do audits. Basically, I've been trying to buff up my CV. So actually, work itself hasn't been too bad. I think with our contracts, it's actually really easy to be able to have a life after work. But with my extracurricular things that I'm doing for work, it takes a lot of time. So depending on how much, that's why I'm like really emphasizing, like, if you can do it early and get it out the way, because it's not only practice, so it makes it faster when you do it again, but it's also, you've at least got one under your like sleeve. Oh, PJ is saying that they have an ENT exam. Oh, no worries. And how many hours are you racking up a week? Okay, so my contract is 48 hours a week. I think that's baseline, but they usually say in the contract, like, you're okay to work extra hours and you have to sign it whether you like it or not. Because essentially, especially when you're a junior, you do end up staying a bit later. But you shouldn't make a habit of that. Actually, you shouldn't make a habit of that. You should actually know when to log out and switch off. Some people have a bad habit, me, to just stay until like you're happy with what you've done in the day. But 48 hours is usual. If you want to do locums on top, okay, if you want to earn some extra cash, you can do some locums depending on what you're comfortable with. And at the end of the day, you should be able to log out, sign off when you're meant to. I wouldn't say get into a habit of staying after. But obviously, if it's learning, you want to go to theatre, this is in your own time, this is interesting for you, yeah, for sure, stay in later. Yeah. Is that everything, everyone? I think it might be.
I think that might be all of the questions.
Right. Well, it was lovely talking to all of you.
Yeah, thank you so much for taking the time to speak with all of us. We really appreciated it, especially all of the like different airway things. I think it's really important for us to know. We don't get to practice it so much here.
Yeah, definitely. There's so many things that I wish, like, if I could go back, I would do slightly differently or introduce. So yeah, if I can shine some light on anyone, feel free to contact me.
Thank you so much. And again, if you want to get in touch with UIMS, we can hand out Dr. Mane's email address, and it's on some of the slides as well. So feel free.
Yeah, if you need the PowerPoint, just ask. I'm free to send it over.
Yeah, I'm not sure if we'll be emailing out or posting it somewhere. I need to check a few things, but it will be accessible for sure somehow. As of yet, unconfirmed how.
Yeah, I'll just leave that to you guys.
Yeah.
Yeah.
Okay.
Feel free to ask me any questions if it ever comes up later and you forgot now. But yeah, thank you everyone.
Yeah. Okay, I think we're good for questions. So thank you very much. I'll stop all of these and we can go. Thanks.